a team of experts had been assembled around the world to get this photo. Anybody know what this is a picture of? First picture in man, right? This is a picture of a black hole, right? We've never been able to see this because of the issue of the singularity. And it really strikes to the heart of, wow, the level of innovation and science that is taken to take a photograph of a black hole, right? I mean, that's truly incredible. When you think about what we do, the putting screws in people's backs, it seems so pedestrian, right? And why can't we be more like that? Well, let me tell you something that's along the lines of this if you're into astronomy and that sort of things. One of the things that we learn about is the extinction of the dinosaurs, right? So there are all these great, gigantic reptiles tromping around the earth, right, if you believe in evolution, and then one day they're gone, right? And this is a shocking phenomenon, right? And I will tell you that as a spinal surgeon, okay, we get very, very comfortable with our scenario, which is that we are the highest paid doctors. And I tell my patients that, they know it. We are the highest paid doctors there are. We're like T-Rex. We're the most susceptible. We're like the canary in the coal mine. We're the rarefied beast that is easily wiped out. Okay? And there are a lot of scenarios that could play out in this sense. Patient fears, right? So all you got to do is open, who reads Becker's Spine? Right? Everybody reads Becker's Spine on the toilet, right? It's fun, right? Because Scott Becker has all the dirt. You want to know who got divorced, who got bankrupt, who got sued. Just open Becker's Spine, right? I don't think there's an equivalent of Becker's Spine for most other fields, especially other non-surgical fields. But patient fears, right? Negative sequelae, demand for services, economic costs. Spine is the number 2 reason for a visit to a doctor. And I tell my patients, why are people so terrified? Like everybody has heard, don't ever have spine surgery. Nothing of the sort is ever said about any other single surgical field in man. Right? You don't say, okay, well, I'm a neurosurgeon, don't ever have brain surgery. You may hear it once, but you're not going to hear from every single person every single one of your patients, I guarantee you, has heard, don't have spine surgery. They don't talk about breast implants that way. They don't talk about hip surgery that way. They don't talk about cardiac surgery that way. There are major issues with how we're viewed and how we do things. Now, I'm not saying they're all based in reality. What I'm saying is that public perception is incredibly powerful, right? So here's a good example, right? We have competitors. Right? So how many surgeons out there have true competitors? Well, our competitors are what? Chiropractors, pain doctors, physical therapists, Dr. Ho's selling braces on TV at night, right? The Laser Spine Institute, right? No other field of medicine is like us, right? So this is a concern, and we may end up like the T-Rex or Triceratops or whatever. The Zeitgeist, right? The Zeitgeist is the key, right? These are the aspects of the current Zeitgeist today. Things like cost concern, paradigms. I was doing a peer-to-peer yesterday. Who's done a peer-to-peer in the past week? Like, it should be every one of you, right? You're constantly getting called about, oh, do you need to do this surgery? Well, guess what? They don't do that to cancer doctors. Cancer doctors don't have to get on the phone, do a peer-to-peer, right? They said, cancer, you got to do the surgery, right? Does that really make sense scientifically? Is that really the reality of what's going on? No, it's the perception, right? And so there are issues like affordability, reproducibility, consistency, complications, the aging population with demand for service. So, it's actually kind of depressing when you think about it, right? You're like, well, what's going to happen to our field? If you care about our field, forget about your individual business practice or your ability to take care of your patients. That's one thing. What about the field in general for your children and future generations? So I'm a nerdy kind of guy. Last night, Larry Koo and Bob Lowe and I are reminiscing about Stanford, and I actually am very optimistic. I think technology is the answer, right? I think technology is the key to so many aspects of what we need to have happen, right? And you can take that further, which is say, is minimally invasive surgery the answer, right? And I think that nowadays, if you ask any single spine surgeon in the entire United States of America, and a patient comes and goes, do you do minimally invasive surgery? Is the answer going to be yes or no? Yes, right? Whether they do or not, it's always yes. Why? Because how can you say you don't do minimally invasive surgery, right? But what is MIS surgery, right? What is this stuff, right? And is it a technique, right? This is something Larry helped put together with the Red Journal, the first supplement with Rick Fessler on minimally invasive surgery. Is it a technology like a tube, right? Is it an approach like a Wiltse plane? Is it a marketing ploy like a Laser Spine Institute? Is it a philosophy of surgery like doing less in a bigger problem, right? Or is it a philosophy of care like ERAS, like enhanced recovery after surgery? So these are all dimensions of spine surgery that could be considered minimally invasive. So very quickly, and I hate the history talks, but very quickly, let's just recap some of this because it's the first talk of the day. This is a great paper, sort of a meta-analysis by Kevin Foley looking at almost 1,000 papers, 30 were included. Here's the forest plot looking at pain. So for you who are not familiar with forest plots, this is all the data. These are the papers, right? And they have these little plots, and each study will show either in favor of MIS on this side or in favor of open surgery on the right side of this line, right? So that's called a forest plot. Good way of summarizing data that's been published. And so if you talk about reduced pain, clearly the studies indicate, whether you believe the studies or not, the studies indicate that MIS reduces pain. Earlier normalization to life, right? Here's another very good paper looking at summaries of, this is a great paper by Adagwa, the paper by Scott Parker, everybody knows. Going with open surgery in orange or MIS in blue, you can see that people are getting back to their normal lives, work, play, walking, all those things much faster with MIS. So this has an economic cost aspect to it, right? If you can get people back to normal faster, that's good. What about infection rates, right? So this is a paper that was put together looking at the infection rates, right? So if you look at this large series, 1,300 patients, right? The rate of infection is 0.22%, which is much lower because in open surgery, it's something more like 2%, right? 2% or 3%, right? So we actually studied this with the Premier database and looked at thousands and thousands of MIS versus open TLIFs, and what we found was there's a significant cost savings when you do MIS surgery, because guess what? When people get an infection, it gets very expensive. You got to wash them out. They need a PICC line. They got to be monitored. There's also medical legal costs, which we didn't even cover here. What about a controversial question like CSF leakage? Like, do you think a CSF leak is more or less likely to happen with an MIS surgery, right? And so this is from Rick Fessler's group, and they looked at this, and they did here's another forest plot, and you can see favoring MIS on this side that you would see less CSF leak, and that makes sense. And why is that, right? But initially, say with the MED system, people had more CSF leaks because they didn't know how to use the endoscope. But then as people got good with MIS, they found out, well, if you don't expose the dura and play with it for an hour, you're less likely to have a leak. Another hot area is narcotic consumption, right? So this is important because of the opiate crisis. So if you look at things like narcotic consumption over time, the amount of pain involved with surgery, a lot less, and then a reduction in narcotics and return to normal. So all these things are very cogent arguments and data in favor of MIS. But then, we're faced with this kind of paper. This is a very, very well-known paper in JAMA, published by the Netherlands group, multi-center randomized controlled trial of microdiscectomy done through a tube or not through a tube. And guess what it showed? No benefit for MIS surgery, right? And for the guys in the room who are pro-MIS, how do you contend with a paper like this that's super high quality? It's level 1 or 2A evidence. It's actually read by referring doctors, right? JAMA is read by everybody who has a membership in the AMA. And so how do you contend with that? And so we've always taken a sort of ideological stance that, wow, MIS must be better, right? But I'm going to take the counter argument, if you will, to say, okay, well, there are some things that you almost always ask about MIS surgery that you almost never hear about open surgery. Now, Jeff, some of your fellows are here, right? So they've come to learn MIS here in this great house in Seattle. And this is a very, very valid issue, which is how do you have a completely different mindset sometimes when you're doing MIS that you're not sure about certain things? For example, when is the decompression done? This is a very common question. When you're not able to see everything, how do you know you're done with that? Where's the nerve root? This may be the most common question, looking for the nerve root. You don't ask that question in open surgery. You know where the nerve root is. How do I get a fusion? Where am I, right? So these are the types of questions you almost never hear about in an open operation. Right? And we can come up with all the arguments, right, of how that goes, but we're along this road and this journey, right? And so as a proponent of MIS, I'm going to make a prediction, okay, that MIS is going to be one of the major drivers of new technology development and adoption, and that's going to matter because it's the only chance we have in the Zeitgeist that exists, right? Whose RVUs are going up? Whose compensation per RVU is going up? Nobody. It's going down, right? Everything is pushing us towards being more efficient and more productive all the time, right? And this is something that surgeons hate, and I'm going to get back to this later, okay? So this is a great paper in the New England Journal looking at some concept called combinatorial therapy for HIV treatment. Now, I went to UCLA School of Public Health, and at the time they talked about smoking and HIV. There was nothing else. And HIV was a death sentence, right? Last I heard, I think Magic Johnson, how many years is Magic Johnson now? 13, 14 years, 15 years? Longer? They don't even know when he got infected, right? So, yeah, so here's a guy who's going, and now you hear about people who are saying, if you just take the Truvada, you can do whatever you want, right? So what a huge change from when I was in medical school, being like HIV was the plague that people were going to we're all going to be dying of HIV, to this, and it came with the combinatorial therapies, right? And I'm not saying this is the panacea. This doesn't make it like smallpox. It's not like it's extinct, but it changed everything. So I like to look and identify trends and what's happening. So this is a slide I actually got from Max Rise, from JoyMax, and I'm not gonna single them out. Let's just talk about endoscopic in general. This is a meeting in China, okay, of JoyMax users. Now you could say the same thing about Wolfer Stores or Eloquence or whatever. Eloquence. I'm not making the point about JoyMax in particular. There are almost 1,000 surgeons assembled in one course, and all of them use this technology. So if you go to China, right, every major hospital, are you Chinese? No? Okay, Korean? No? Or Thai, from Thailand, okay, great. If you go to any major hospital in China, level 1 hospital, there's 1 or 2 or 3 orthopedic spine surgeons who only do endoscopic. They don't do ACDFs, they don't do deformity, they don't do MIS TLIF, they do just endoscopic surgery all day long, 6 days a week. That opened my eyes. I'm like, how is it possible that in America people are like, endoscopic, that's for like Tony Young and nobody else, right? And then you go to China or you go to Germany, you're like, holy crap, these guys, there's like a whole service line dedicated to endoscopic, and they do nothing else. Well, it must work for something, right? So that's kind of a big deal. And then I looked at robots. So this is at the CNS meeting last year. There's 1, 2. I'm not going to go through the names because Linda doesn't want me to call them out. But there's 13 robots, okay, on the market, right, of various sorts. They do various different things in neurosurgery. And robots are big. And you could say it's the year of the robot. So for a while now, we've been working on our Awake Fusion or ERAS surgery program, and we've come a long ways with this, okay? And we've combined endoscopic with awake anesthesia and specialized percutaneous fixation with long-acting liposomal bupivacaine, expandable cages, and osteobiologics. And the data are pretty impressive in what we can do with the MIS surgery. So this is just some basic data for you to look at, right? We've done now about 220 cases. We follow these people very closely, and so we're doing basically a TLIF, fusion, cage, screws, bilateral, without using general anesthesia, and it changes everything. The patient comes into the room with an IV, nothing else, no Foley, no Bovie. They flip themselves over on the table and we start the operation, okay? So this is an example. This is a case that you cannot do generally on anybody, which is injection fraction to 11% on an 86-year-old, okay? To me, that's a no-go in my anesthesia house. And what you can see is the patient's here. He's going to get awake fusion for a grade 2 spondy. He's got pacer pads on because they think his heart is going to stop, right? And actually worked great, right? So the issue, though, with this surgery is that, you know, and this is sort of the video of the first case we ever did in man. This is back in 2013, I think. We're talking to him. We're doing a fusion and all that. But there are issues with this surgery, right? The issues are it's not easily taught. And so people are like, well, how do I access Kambin's triangle, right? How do I use and place the endoscope, right? I want to minimize radiation, right? Especially if you're from Asia, right? I can't get, osteobiologics, right? So we had to come up with a solution that was a little bit different to try to translate this across platforms. In other words, you could go into almost any hospital and potentially see this surgery happen. So we started to merge the robotic and endoscopic technologies, as Jeff said. So this kind of shows a case. So this is Jason Leonakis is one of our current fellows, helped me put together this video. And this is still early in its stage. So you can see we have a similar setup here where we're going to do the awake fusion, except we're going to do this asleep because right now we don't want to start with awake with the robot because that's an issue right now in terms of how the FDA does that. So we're going to hook up the robot. In this particular case, we're going to use a Mazor X, right? So you could probably use any of the 3 robots to do this, but we have a Mazor X. We actually have a Rosa as well, and hopefully we'll have an Excelsius soon too. So we're connecting. Oh, are we stopped there? Oh, sorry. You know what? Is there like a delay on this? Oh, we lost our AV guy. I apologize for the video hookups. Let's see if it'll work this way. We'll do that. We'll do, yeah, it won't run, will it run off of outside of PowerPoint?
Yeah, just play it.
It's just not going on that.
Here, I'll show you. Where's the
Yeah,
video?
it's right here.
Just drag it over there.
Oh, drag it over there, okay.
Oh, it just went back. Hold on a second.
Oh, okay. Oh, that's cool. Okay,
There you
perfect.
go.
Perfect. Sorry about that. So what's going to happen is the robot's going to register after you're connected, and then we're going to put in the O-arm. So this is one of the things we wanted to do, is avoid having to get pre-op CTs on everybody. And we're spinning the O-arm, and then the robot's going to scan, and then we're going to start. Now, the interesting thing about this is this allows us to do everything essentially with the robot. In other words, this is not like you open, expose, and all that, and then you do the screws with the robot, and that's it. We're going to do everything basically with the robot except for some of the endoscopic manipulation. So in this particular case, we're going to start by putting our screws in first, because once we start the inner body work, we're going to change the dimensions of the disc space. So we need to have that registration accurate, and the robot's going to help us target and place our K-wires for screws. We're not going to put our screws in just yet because they kind of get in the way, especially that caudal ipsilateral screw kind of gets in the way of your working channel, right? And so, oh, maybe we do put the screws in first. Okay, yeah, so anyway, so we're going to do all that and get that targeted, and then we're going to target the disc space. So this is really where we combine the endoscopic with the robotic technologies, where we're going to be able to get in, and we're going to use electrophysiologic monitoring, because the patient's asleep now. They're not awake for these surgeries yet, although that's the next iteration. And we're going to get in there, and we're going to place the endoscope in through Kambin's triangle. And this has allowed us to collect all kinds of specialized data, because now we know where we are in Kambin's triangle. So we're able to now, for the first time, establish electrophysiologic parameters of what the DRG stimulation is. We all know what the nerve root stimulation is, but the DRG is a different structure, right? So we're going to go in with the endoscope, and we're going to essentially clean. You can see we're now working with the endoscope inside the disc, cleaning it and preparing it for fusion. After the fusion site is prepared, we're going to use our expandable cage. So the cage is going to go into the disc space. You can see, again, no bovie, no opening. Everything is done essentially percutaneously with robotic guidance. And now we use the floor. The reason we use the floor is because when we put the cage in, we need live information. The robot and the navigation isn't going to tell you where the cage is. So here we are, cage going in. We're checking it, and we're going to do the expansion, osteobiologics. And that allows us to then get decompression with the endoscope, targeting, cage placement, and screw placement, all without having to open the body at all, and all with using sort of, if you will, much less X-ray, and maybe most importantly, much less sort of surgeon intelligence, right? Much less of what I would normally have to do to, oh, how do I do this? Now I'm over here now, right? So I got to go there. Okay, great, perfect. Thank you for doing that for me.
Mike, was that a cage or biologic? I didn't see a titanium cage.
Like a bag of bones?
Yeah, so I hate that term, right? Because it's like, it's a pejorative term that was used to basically destroy that company. No, we're using an expandable mesh cage. We're using OptiMesh in this particular case. But I think that in regards to what kind of cage you use, it's almost, I don't want to say it's irrelevant, but all the cage companies are moving towards getting smaller and smaller, right? So currently, the only cage that can go through a size of 7 millimeters is that cage. Like that's the issue, right? And I know that Globus has developed some cages for endoscopic that hopefully, are going to get some adoption. I'm not sure about the size about that, but it's definitely an issue that is being solved. So if you look at our sort of awake fusion, and Alok is going to talk about awake fusion as well in sort of a different light, which is very impressive. We're taking away that piece, but we're replacing it with the robot. And so if you look at what we are trying to accomplish with each of these 6 arms, we're trying to get with endoscopic visualization and working channel miniaturization. The robot gives us accuracy, the percutaneous fixation stabilization. And this is important because, I can talk to you all about perc screws and at different sizes and different brands and all that. There are differences in how you use screws. All perc screws are not created the same. Long-acting sodium channel blockers for pain control, expandable interbodies for distraction, correction, and fusion, and osteobiologics for getting that solid arthrodesis, right? So this is all pretty important, but let me ask you guys, who has a robot in the room? Okay, so like one out of 8 or 10. Okay, so anybody know what this is? Jeff, do you know what that is? That's an early Chinese compass. That's one of the earliest types of compasses that they use for navigation, and Chinese invented a lot of things, including the compass, right? And if you think about it, like in and of itself, like it was pretty powerful, right? But it was limited. Now comes navigation by stars using the sextant, right? By sky, right? This has a lot of intrinsic value because now you know your position on the globe a little bit better. And then, of course, in the 1970s was the launching of the is it called geodesic satellites? The satellites that allow you to know where everything is in space through GPS, right? And that was initially only for military application, and then it became possible to use it for commercial civilian application. Now you see where this is headed. And then you get to something like Waze, right? Waze was invented by Israelis for Los Angeles after the Loma Prieta earthquake to get around the 5 freeway, okay? And that company allowed you to find out how to get from A to B in the best possible way. And then, of course, the next generation is the self-driving car. So you can see that as you go through technology, you say, well, the people who are relying on the compass, they're like the master surgeons. They're like, yeah, I don't need any of that. I'm better, right? I'm faster. And there's a great quote. I know Martin did a fellowship with Larry Lenke. Larry Lenke has a famous quote saying he kind of started to get it about pedicle screws after 10,000 screws. Now, that's a lot of screws, right? And that's a lot of time, and that's a lot of hazard to a lot of human beings to get to that point. But people are scared of robots. People are really kind of terrified. I know we'll have some talks about robots later, but a year ago, there was this case in Arizona of a woman being hit by an Uber car. She was jogging or walking on the street and was hit and killed. Here's in northern Florida, near University of Florida, this guy was on his Tesla watching, I think it was Game of Thrones or Lord of the Rings or something like that, and went underneath a semi-truck and decapitated him, right? That's an example of reliance on that. We're near Boeing Field. This is 737 MAX, right? What is the value of technology? I'm sure the software was released as an effort to make pilots better, right? But unintended consequences. And are you guys aware of any robots killing humans yet? That's fascinating, right? The media is so powerful and so wrong, right? Robots have been killing humans for some period of time now. Here's an example. This is the first documented robotic death of a human. This is in a VW plant in Milwaukee, Wisconsin, okay? 1979, this guy, Robert Williams, young man, was killed by a car manufacturing robot. Killed by the robot, right? Didn't even hear about it, right? So people are like, well, someday it's gonna be like Terminator. Well, it's already kind of here. This is unintended, right? This is unintended consequences, but this is 30 plus years ago, right? Let me show you an intentional robot kill. And I'm not talking about drones, not military application. You guys remember in Dallas, Texas in 2016, there was a big shootout. This guy was a sniper and was hunkered down inside the federal building, killing off police officers in the middle of the night. So basically all the police officers came in. He was socked in using a sniper rifle, just shooting police officers, killing them dead, right? You guys remember this incident? It was a big deal, right? And this is what happened. And this is the fascinating part about how humans are, how susceptible we are to change. So they couldn't get the guy. Look at all these guys. They couldn't get to him. This guy's trained. He's military trained. So what they did was they took their robot, the police robot, the bomb robot. You know the robot that goes out and touches the bomb and all that? And they stuck a bomb on it. And they sent it, they said, we're bringing it to McDonald's or something like that. I can't remember what it was, but they bring some food to him, right? Because he had him on the phone. So they send the robot up, this little thing with a bomb on it, up to him and explode it, killed him. Okay, now, this will go down in history as a sentinel moment in history, because this is the first time a robot was used in a civilian practice, forget about military, to kill a human being intentionally, right? Now, you can argue the merits or drawbacks of that, but that's important because we're already in this era, right? So what's the point of all this? The point of all this is that we're trying to overcome learning barriers, as everybody here in this course is doing, improve accuracy, and of course the risk is to the DRG, the dorsal root ganglion, standardize the procedure, make it so everybody just does it the same and it's like a knee or hip. removing traditional impediments to technical success, right? And of course, most importantly, advancing patient care, right? And I'll tell you that we all have our butterfly collection. Juan Uribe talks about like, oh, this is my great case of this. It's not like that, right? I have all kinds of disaster cases, and I could show them to you if we weren't being recorded, right, for the world to see here in Seattle. But we all have disaster cases, and I am happy to share them with you and the lessons learned through all of this, right? But there's a lot of things coming next, right, like robotic decompression, bone removal, improved MRI instead of CT-based registration, superhuman visualization. You ever thought about this? The kind of light you use in an endoscope matters. We're so used to just using xenon or whatever the bulb is. What about using special frequency laser lights so you can see blood vessels or nerve better? That's very, very straightforward, right? That's well worked out. Control of intraoperative motion, right? This is an issue. What if I am older and still very intelligent, but I have a tremor and I can't operate? Well, but what if I had assistance with a robot and my brain could still be used in a way that's meaningful? Maybe a lot better than a younger surgeon who's not knowledgeable, right? So you're changing the human element of this. Automated rod bending, placement, efficient disc removal, deformity correction, all this is pretty simple, right? Now, again, like Jeff and Larry, I'm an Asian dude. I'm very geeky, and I always think about this because they always say, well, what about the cost, right? It's so expensive. And my dad worked at Georgia Tech. He was a professor there. And he brought home a computer, and the computer had 2 floppy drives. Okay, first of all, that was impossible to find. The computer cost $5,000, okay, and that was 1981. Does anybody have any idea how much that would cost today, $5,000 from 81 to 19? It's like $30,000. Okay, so tell me where you go, maybe here in Seattle, to buy the $30,000 personal computer. There's no such thing. Right? So when people go, well, this is like about as useful as like a calculator, right? And this is what everybody's using today. Which one's more expensive? This one's more expensive. So you have to decide if you're going to be at the cutting edge or not. And let me show you some really compelling data and why we doctors are such laggards. This is a plot showing this is cost in dollars, log scale, and this is years 1940 to 2010, okay? This is for the computing power of an iPad 2. Okay, now, anybody know how much iPad 2 costs? That's like the new, you got the big fancy one, Larry. No, the simple iPad 2, like the simple, like $198 a Target, okay? $198 a Target, right? So that's how much it costs, right? This is today. The computing cost for that, let's just go back to 1960, was $10 billion. Okay. Now, this is important. Why? We all know about Moore's law and all that, right, about how technology doubles. But what doesn't seem to happen is healthcare doesn't seem to do that. In other words, who does double the number of cases they did when they started? I do. Yeah, I started 200 cases, now I do 500. Okay. Who does 10 times? I'm not doing 2,000 cases here. Who does 1,000 times? I'm not doing 200,000 cases, right? But that is what we're being held to as accountability. That is what the rest of the world does. We say, oh, I did 8% more. I saw 8% more patients this year. Guess what? If computers and cars did that, we would all, we'd all be fired. It's crazy the difference in what happens. And so here's one of the take-homes. This is George Bernard Shaw talking about surgeons resisting change. The reasonable man adapts himself to the world. The unreasonable one persists to adapt the world to himself. That's the crazy person. All progress rests on the unreasonable man. So when your hospital administrator says, why don't you just comply with this, that's one of those issues to think about. So thank you, Jeff and Rod, for putting on this great course. Hopefully we'll all get to learn a lot.
All right, let's open it up for some questions. Anybody? Come on, there's got to be some questions out there. Larry.
So you have all these really cool tools.
Can you guys be sure to, there are these little microphones in front of you. You just have to press down on that front part of it. The green light will go on.
We have a lot of cool toys. Yes, we do, Larry.
Yes. Oh, sorry. Oh, right, cool. That button. Sorry, my bad. Pushed a lot of things. So Mike, you have the robot, you have the O-arm I saw in there in the views and things like that. One of the things that you're talking about, cost, learning curve, time in OR, the monetization every 15 minutes in OR, we have all these metrics that we have to hit, right? And like when you and Matt did the cost analysis, you factored in OR costs too, right? Because that's a direct cost to the hospital.
Right.
So my question is, what has been your strategy to minimize the impact, like you said, of the adoption curve, Moore's law, and then Turner's adoption law curve? How do you, like the O-arm, 30 minutes, 40 minutes, typically for initial implementations, right? That adds time. And then the minimally invasive screws that come from it, you save 15, 20 minutes. So there's a math at work, right? How have you personally, on a device-to-device basis, robot, C-arm, O-arm, endoscopic towers, how have you kind of gradually implemented so that the impact doesn't shift your curve so that you don't look terrible to your hospital, or you don't look terrible to payers?
So from the hospital administrator standpoint, right? So I can tell you, right, so every one of these 6 technologies they pushed back on. But I will tell you that, and it's been published now, I had to wait for the CFO of the hospital to leave to publish the data because it's so sensitive, right? Cost data is true cost data, not some bullshit cost data, right? So we have the cost of a TLIF on average down to under $19,000. Which is astronomical, because a DRG on a Medicare patient is $34,000. That means that my profit margin on TLIF is through the roof, right? And the reason is because everybody else is adding costs on it, as you say. So that gives me a little wiggle room to then go and get the robot. But guess what? We're not paying $1 million for the robot, right? There's ways to work this out from a cost perspective. I would tell you that the job of the university is always to be at the front end, but you often find that the universities today are not at the front end anymore. They don't want to lead. They just want to make money, right? And by the way, if anybody thinks it's like here in Seattle, our hospital, and I'll say this on tape, but I'll probably get fired when I get back, our hospital has 14 days of cash on hand. You know what that means? We're a B- bond rating. Yeah, we're a Chinese restaurant. We're basically, yeah, like a small one, not like, yeah, right, exactly, not Panda Express. So, so it's a real issue, right? And I'll tell you that the hope is that we are analyzing, we're recording all these videos of every surgery, and we're analyzing where the choke points are. We're taking the industrial engineering perspective, because we're humans, right? So that's the interface. Industrial engineering is the interface of the humans, operations research, human and machine. And if we can't solve that problem, then nobody's going to do this. You're absolutely right, Larry. Everybody looks at it and goes, well, I don't have time for that. But the answer is, what about, a lot of people say, I want to make the really good surgeons super. But I'd say, what about just getting the surgeons who are just trying up to a certain level? And I think that would be the biggest public health service.
Mike, I have a question about endoscopic surgery. You showed that picture of like almost 1,000 Chinese surgeons all doing endoscopic spine surgery, right? And the same is true in like Germany and South Korea, where it's becoming the standard of care, So what are your thoughts on like adoption rates? And why is it so discrepant here in the United States versus elsewhere in the world?
That's a great question. So I'm going to say this again, and we're on tape, so I got to be careful. But I'll just say, I'll speak my mind. Spine surgeons are the highest paid doctors there are. Okay? They're the highest paid doctors there are. They also assume the most risk. We're the most likely to be sued. That is the hardest population of people to change. People making on average $700,000 a year who are afraid of getting sued. Those people do not want to change a darn thing. They want things to stay like this forever. So if you take 7 hours to do a 1-level ACDF, fine. You're doing great, actually. You're fine, right? There's no selective pressure. So the reason I show the picture of the dinosaur is because T-Rex was not ready for the asteroid or the diarrhea or whatever it was. When that hits, the reverberation through the spine community, I mean, there is no other field of medicine like us, or very few like us, that have like so much support from industry. And like, you can go to any hospital and just set up shop. Like, talk to your ENT friends. See how easy it is to find a job. Urology, go ask them how easy it is to find a job, right? And you will be shocked. So right now what you have is you have 8,000 spoiled children, and they say, I don't want to learn it. And you know what? It's 13 RVUs. So the only people that will do it are ones taking cash. Right? So you say 13 RVUs. Well, why would I do that? I'm going to do a T10 to pelvis like Martin and get 130 RVUs, right? I'll tell you, honestly, we're the biggest spine center in North America in Miami. None of my partners do any of these things. They all do big whacks. I was talking to the guys at UCSF. They're like, why should I ever change? I do 1 PSO a day, 130 RVUs, right? Like this. Yeah, because 130 RVUs a day, twice, yeah, right, it's true. That's what they say to me. They're like, you're MIS, I don't like your MIS, because guess what? They're going, I make 25,000 RVUs and I work 3 days a week. And the question I have for you is that sustainable? Like, what is going to happen? Well, how will history judge us? And they go, whoa, your average cost of surgery, anybody know the average cost of a T10 to pelvis? $300,000. Yeah, right. The average cost of doing that operation, signing that patient up, is $300,000. That's a Ferrari. I mean, that's a house, right? And so you're just going to whack like that, whack, 300 times a year. So we're a bunch of spoiled, and I'll say it on tape, we are a bunch of spoiled children. And when the asteroid hits, there's going to be a lot of crying. But I'll tell you who will be standing. I'm going to be standing. Jen Shen's going to be standing. We're still going to be here because we're able to overcome all of that because we see the future. The future is clear. One senator, one congressman is going to come and say, wipe it out. And they're going to save billions, hundreds of billions. But then there's going to be a lot of crying. And I hate to make it negative, but I think it's the beginning of understanding. Like, go back home and say, wow, how much does it really cost to do what I do? And then you go, whoa, like maybe I should try to improve a little bit. So that's my take home. So that's why endoscopic hasn't taken off. Because why would you have to believe if it's 13 RVUs? Yeah, Larry, go ahead. Sorry, I'm taking too much time now.
That last thing you said is very important. I think it's very important to also mention the quality of life year initiative at the public health CMS level, right? The crackdown, and you see it from guidance documents from CMS right now, that they're going to start cracking down on quality of life years. Like a total knee is $24,000 for a quality of life year to get one person with a knee problem back to healthy life, functional life, right? Like to your point, a T10 pelvis quality of life year yields, according to the SRS, is like $185,000, and cut off for meaningful surgeries is around 30, right?
Right. So you're 6 times over what's meaningful. Yeah, it's crazy.
They won't pay for it.
They won't pay for it. It's coming. It's definitely coming. Yeah.
Right.
Okay, thanks, Jack.